A very good afternoon to everyone. So we are here again to for yet another webinar with the Cutting Edge series webinar which we have every Tuesday. And today's webinar is in association with Ajmer and Kota Society. I welcome everyone, all the delegates, the faculty, esteemed faculty for this webinar. The Cutting Edge webinar series has given us a platform to interact with all the colleagues all over India, our OBGYN colleagues, which helps in maintaining a camaraderie between all of us and also sharing knowledge. So I welcome you all for this webinar. I request the organizers to start a prayer so that we can have an official inauguration of the webinar.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
Thank you. Now I request our President, Dr. Aarti Nimkar, President POGIS, to give her presidential address.
Hi everyone, I welcome you all for this webinar of the Cutting Edge. We have started from last year and now we are continuing it. Today it is with the Ajmer OBGY and Kota OBGY Society. I welcome all the Kota OBGY Society faculty and which are watching or hearing this webinar and also from the Ajmer Society. So we are today having the guest of honor, that is Dr. Deepak Dej, senior IVF specialist and laparoscopic surgeon from the Kota, and Dr. Deepali Jain from the senior professor of the OBGYN from the Medical College Ajmer. Now the first session will be by the Vaishali Sawan, Dr. Vaishali Sawan. She is going to speak on the preeclampsia screening in the neo-adolescent. And chairperson for her, there's Sandhya Rani Chaudhary, President AOGS, and Dr. Khushbu Meena, General Secretary from the Kota of Gynec Society. And second session will be by Dr. Suchitra Narayan on the iron deficiency anemia and treated by the efficiency of the FCM in the treatment of the iron deficiency anemia in the pregnancy and BPH. These chairpersons are the Ritika Masood, President KOGS, and second, who is the second chairperson? Sandhya?
It's Sandhya.
Please say, I am chairing.
And Sandhya will conduct this webinar. So, Sandhya, please go ahead.
Thank you, ma'am. Thank you for your kind words. I request Dr. Vaishali Sawan, who is the Vice President-elect POGS 25-26, and also she's the Vice President West Zone Foxy electoral candidate for the next year. So I welcome Vaishali ma'am to say a few words.
Thank you, Sandhya. It's indeed a great honor for Pune Obstetric Gynec Society to have such eminent, great leaders and eminent faculty with us today for Cutting Edge webinar. And we have this webinar every Tuesday, 4 to 5 p.m. Dr. Meenu Agarwal had started these interesting webinars. And we are truly, truly grateful to Dr. Deepak Das, Dr. Deepali Jain, such senior members who are here today as a guest of honor and who will be giving us their blessings. And Ajmer and Kota Society was so very cooperative. Last minute, we arranged all this webinar. Dr. Sandhya arranged everything. And because of the response we got from you, we could arrange this webinar quickly and carry on with the academic program. So thank you very much, Dr. Suchitra, Dr. Sandhya, Dr. Khushbu, Dr. Ritika, and all the speakers and chairpersons who are here. So I think, Dr. Sandhya, we can move ahead.
Yes, thank you, ma'am. Now I request our General Secretary, Dr. Meenakshi Deshpande, ma'am, to kindly introduce both the guest of honors.
Yeah, thank you, Sandhya. And at the outset, as the Secretary of Pune Obstetrics and Gynec Society, let me welcome all the faculties of Ajmer and Kota Obstetrics and Gynec Society. We are very happy to have you here on the POGS platform, Madam and Sirs. And we would really like to take this forward. We would also like you all to spread the word that Dr. Vaishali Chavan, our from Pune POGS, is standing for the post of VP next year. So we would like all of you to support her. And of course, from POGS, we would be very happy if she comes up as a VP of Foxy next year. So I would like to introduce now Dr. Desh Deepak. So are you here?
Yes, madam. I'm here only. I'm
Yes,
with
sir.
mobile.
Yes. So he's a director of Rajdeep Fertility Hospital and Research Center from Kota, Rajasthan. He is an organizing secretary of the West Zone UA Foxy Conference 2022 and an organizing chairperson of the State Conference of Endoscopy, AGESCON, in 2019. He was also the organizing chairperson of the State Conference Rajasthan, and he was the ex-president of the Kota Obs-Gynae Society from 2017 and 2022 to 23. He is specially interested in endoscopy, high-risk pregnancy, BOH, and of course the USG. He is the pioneer of advanced endoscopy and IVF in Kota region, and in his credit is the first IVF baby, the first ICSI baby of Kota region. Wow, congratulations, sir, for this achievement.
Thank you.
And we welcome you to this webinar today. And who is going to introduce the second chairperson? Guest of honor.
Ma'am, will you introduce?
So let us ask Sir to give his blessings and then
Okay, then we'll go.
introduce,
Okay.
Deepali
So
ma'am.
please give your words of blessings for this webinar.
First, thank you to Pune OBG Society to include the Kota Obstetric Gynec Society in this webinar. And basically, webinars, we are connecting each other like Kota, Ajmer, Pune, and having good interactions about the subject and about us also. And my best wishes to Vaishali Madam and everybody for the future. And we should continue our academic session now.
Thank you, sir, for your blessings. It's a great honor for us, sir, a great personality, well-known leader who you are here today. And I have seen your videos, sir, laparoscopic videos, and
Thank you, madam.
you are truly an inspiration. And it's a great achievement. You are the pioneer of not only laparoscopy, IVF in all factors. You are there, sir, as a leading leader of the association. So to receive your blessings means a lot, and your presence has truly enriched the webinar. Thank you, sir. Thank you very much.
Thank you very much.
Sandhya, can we introduce?
Yes,
Deepali ma'am?
ma'am, I request Dr. Meenakshi to please introduce Deepali madam only.
Oh, one sec. So we invite Dr. Deepali Jain as our guest of honor. Is she here, madam? I think yes.
I'm there, ma'am.
Yes. So Dr. Deepali Jain is from SMS Medical College, Jaipur. She was the alumni of Jaipur and Ajmer also. And I can't read the lowermost. Teaching experience of 30 years and served as HOD from 2021 to 2023. She's of course the member of Foxy and the member of Menopause Society. She's attended various conferences as reputed faculty. She's the examiner for undergraduates and postgraduate examinations. She's published various articles and papers, national and international levels. So we welcome you, madam, and request you for a few words of blessings.
Thank you very much, madam. And comparing myself with Dr. Deshpande, I feel a little intimidated. I do not have too many laurels and feathers in my cap that way. But all the same, it is only my long-standing teaching experience, and I feel overwhelmed by the fact that you people have really accepted, invited me as a guest of honor. So I'm indeed thankful to the Pune OBGYN Society for giving me this honor and to be part of today's very interesting academic feast. And so my profound gratitude for this gesture goes to Dr. Aarti, the president, Dr. Meenakshi, General Secretary, Dr. Meenu, Dr. Vaishali, Dr. Amol, Dr. Sandhya, and rest of the very all brilliant team members. But I'm glad to notice that there is a changing trend in today's modern practice, wherein we are moving towards generating awareness about the preventive aspects of treatment. So, opening these windows and throwing light on how to early diagnose diseases. And today's very interesting topic happens to be, clinical entity, HDP, preeclampsia, it's early diagnosis and screening. And if we do that, we can confidently treat it thereafter. Likewise, effectively managing iron deficiency anemia with this wonderful molecule, FCM. So all these interesting topics are really going to be throwing a lot of light onto how we in the futuristic years are going to be managing diseases, grounding more at the grassroots level and preventing diseases. So I feel very happy that a lot of work has been done and you people are taking a wonderful initiative. So I welcome all the dynamic speakers and my blessings for a grand success of today's webinar. Thank you so much. Thank you for including me.
Thank you, Jain madam. It was a pleasure having you here.
Thank you, ma'am. And we would like
Thank you.
your presence to be there during the webinar, and we would like your valuable inputs. And it's a matter of great honor for us to have such a reputed teacher amongst teachers with us. And we would like to have your valuable inputs. Thank you, ma'am.
Thank you. Thank you very much.
Thank you, ma'am, for your kind words. Now we move on to the first academic session, and that is on preeclampsia screening newer horizons. And for the first session, I would like to call upon the chairpersons. So Dr. Sandhya Rani Chaudhary and Dr. Khushbu Meena madam. So I'll introduce them. Meenakshi madam, will you please introduce Dr. Sandhya madam? She is not joined, but she'll join sometime.
Can I introduce Sandhya? Anyway,
Yeah.
I'll introduce Dr. Sandhya Rani. Then we can introduce the second chairperson. No problem.
Yes.
I hope we will have Dr. Sandhya Rani Chaudhary as soon as she becomes free to this webinar. She is Associate Professor of OBGYN in Ajmer. She's got a special interest in high-risk pregnancy and minimum invasive surgery. She's published papers in national and international journals and also presented research papers in national conferences. She's worked as an internal and working as an internal and external examiner for UG and PG. She is the ex-secretary of Ajmer OBGYN Society and currently the president of Ajmer OBGYN Society. So we welcome Dr. Sandhya Rani Chaudhary to this webinar as a chairperson.
Thank you, ma'am, for the kind introduction.
Yeah, Dr. Sandhya.
Yeah, I would like to introduce our next chairperson, Dr. Khushbu Meena madam. She's an associate professor, Government Medical College, Kota. She's a secretary of Kota OBGYN Society, presently 24-25, member of FOXY. She's a master trainer of comprehensive abortion care services at Regional Center, conducted labor workshop in FOXY Zonal Conference 22. And her areas of interest include high-risk pregnancy, infertility, gynae-endoscopy surgeries, and surgeries. Yeah. And so we welcome Khushbu madam. Welcome, madam. She had joined actually.
Thank you, ma'am.
Welcome, ma'am.
Thank you, ma'am. Thank you.
Yeah. So
Thank you.
So I request Khushbu Madam to introduce Dr. Vaishali Chavan, our speaker, formally, so that we can begin with her talk.
Good afternoon, everyone. Thank you for giving me such a good opportunity to serve you in a Pune Obs and Gynae Society as a chairperson. And it's my honor to introduce Dr. Vaishali Chauhan, ma'am. She is the clinical director of Cloudmin Hospital, Kalyani Nagar, Pune, director of Sanvi Clinic Women's Healthcare Center. She is the vice president-elect Pune OB/GYN Society 2025-26 and Honorable General Secretary Pune OB/GYN Society 2023-24. She had a various publication, chapter in various books, contribution many Foxy focus chapters in international publications, and she received various achievement in the Samja Bhushan Award, Vaidevak Gaurav Purashkar, and Lokmat Award,
Thank you, ma'am.
Inspiring Gynecologist of the West India, awarded by the Economic Times. It's a great honor to introduce Madam. Thank you for thank you to give the opportunity to Kota Obs and Gynae Society for this platform. Thank you very much.
Thank you, Dr. Khushbu, for the kind introduction. And I'll start with the topic immediately. I would like to share my screen. Is my screen visible, Mr. Prasad?
Yes, ma'am. Yes.
Yeah. So my topic is preeclampsia screening newer horizons. And So as we know, preeclampsia leads to eclampsia, and that kills, it's a killer, it kills the mother, it kills the baby. So preeclampsia, eclampsia causes huge amount of maternal deaths, fetal deaths, newborn deaths, as many as 46,000 per year globally, and newborn deaths also. So it's very important, though in India, we see there's a decline in the maternal mortality, and it was maternal mortality was 130 in 2014, but it has been reduced to 97 per lakh by 2018 to 20. So that is very commendable. But it's also important to know that mortality which is associated with hypertensive diseases of pregnancy is difficult to prevent. And even today, every 7 minutes, one woman loses a life due to this preventable disease. So preeclampsia, we know, is a multisystem inflammatory disease which occurs beyond 20 weeks of pregnancy. And it has two things. One is hypertension, more than 140/90. Other is proteinuria. And recently, there are a typical variant of preeclampsia like hepatic, renal, hematological, even in the absence of proteinuria. So we know every antenatal patient, we do their blood pressure checkup, we do a dipstick for proteinuria, and this is a protocol which most of us follow. But is it enough to for early diagnosis or screening of preeclampsia? Unfortunately, only doing these two things is not going to help us in screening for preeclampsia. So earlier we used to think preeclampsia is very dangerous, very poorly understood condition. But today we know that there are methods by which we can predict. Now I'm going to talk about two methods. One is the screening method, that is the HDP Gestosis score. And this score is based mostly on the clinical aspects of the patient. And the second, in high resource conditions, where we take into consideration 4 to 5 factors, and that is the maternal demography, that is the maternal risk factor. Second is mean arterial pressure. Third is uterine artery PI. And fourth is placental growth factor. And this is by the Fetal Medicine Foundation. So we need to understand what really happens in preeclampsia is there is abnormal placentation. The syncytial trophoblast enters into the blood vessels and replaces the endothelium, and it replaces by trophoblast. And in normal pregnancy, what happens is, you can see in the figure on the right side, the blood vessels become big and tortuous, and more blood flows through them, and there's more oxygenation of the placenta. But in preeclampsia, what happens is the spiral arteries. The spiral arteries are the one which are the closest, they're near the decidua. They there is abnormal formation of this defective trophoblastic invasion. And because of this, you can see the spiral artery is so thin and it undergoes vasoconstriction. And there's an endothelial dysfunction. This releases the inflammatory proteins. And because of this defective trophoblastic invasion, there's vasoconstriction and necrosis. And because of this, whatever biomarkers we are going to talk about happen due to the placental vasoconstriction and the necrosis, and all these biopeptides are released. And these are the biomarkers which we are going to use to predict preeclampsia. So there's an entire cascade: abnormal placentation, placental ischemia, vasoconstriction leading to FGR, abruptio, preeclampsia, HELLP syndrome, and so on. So preeclampsia and FGR usually go together. So in preeclampsia, the current concept says because of the placental ischemia, vasoconstriction, what happens is the uterine artery flow reduces. The PAP-A is again a protein which reduces.
I didn't get that. Could you try again?
And the placental growth factor reduces. And if there's reduction in the placental growth factor, then obviously the placenta is not going to grow, and then there is going to be uteroplacental insufficiency. Because of the vasculature compromise, what happens is SFLT is again a biopeptide protein that it increases, and there's reduction in the VEGF and the placental growth factor. And all this leads to end organ damage, hypertension, proteinuria, coagulopathy, liver dysfunction, and so on. So the biomarkers of defective placentation, because of this defective placental endothelial trophoblastic invasion of the spiral arteries, is mean arterial pressure, uterine artery, and serum placental growth hormone. So every gynecologist, every obstetrician does NT scan. Even when you do a NT scan and double marker, you can pick up and you can do early screening for preeclampsia. And how is that? When you do an NT scan, you look for aneuploidies, structural defects, and so on. But you also do double marker. And in the double marker, if the PAP-A is low, PAP-A we know we use for down screening, but if the PAP-A value is less than 0.35 MOM, multiples of medians, then this patient is high risk for preeclampsia. So it's a very simple method by which each and every obstetrician can pick up even with a simple PAP-A. Placental growth factor is again an angiogenic factor, and these levels are low in preeclampsia. SFLT soluble FMs like tyrosine kinase are also used in prediction of preeclampsia. So let's see what the guidelines say. There's NICE guideline 2019, ACOG 2018, and the Canadian guidelines. And they say that whenever there are moderate or high risk factors, then ecosprin, aspirin should be given. NICE guideline says 75 to 150 milligram, ACOG says 81 milligram, and Canadian guidelines are a little unclear. So what it really means that when all these factors are taken into consideration and all these parameters are filled into a software and an algorithm comes out, and if we use these factors, and if the patient is negative for preeclampsia, then almost 99.8% patients will not get preeclampsia. So these are very strong predictors of preeclampsia. So talking in detail about each predictor, one is uterine artery flow velocimeter. And how do you predict? You take right uterine artery, left uterine artery. PI, we do not use notching anymore. So PI of right and left divided by 2. So average of the both is what is going to help us. A mean arterial pressure. So there's a specific way of taking a mean arterial pressure. Patient should be sitting in a chair with back rested. The legs should not be crossed, they should be uncrossed. The sphygmometer should be at the level of the heart on the arm, and BP is taken. So there are 4 readings taken, one right side, left side, right side, left side, 4 readings with 1 minute difference. The patient should not be lying down. You should not take BP lying down. The patient should be sitting. And when you have to take 4 recordings of BP, it is a process, but it is going to help us. And the average of all this is the mean arterial pressure. Coming to the other points, the NHS and the NICE guidelines and ACOG guidelines, they have also enumerated what are high risk factors and what are moderate risk factors. High risk factors are like previous preeclampsia, chronic renal disease, chronic hypertension, diabetes, SLE, or APS. In moderate risk factors, the NICE guidelines have taken age as more than 40, and in ACOG, they have taken age as more than 35, though the Americans have also included the Black people as moderate risk factors. So when you think about the maternal high risk factors, uterine artery Doppler, mean arterial pressure, and biochemical factors like PAPA and placental growth factor, and you put this all in the software, and then you will get a reading, and by which we can predict that yes, this patient is high risk for preeclampsia. And there are various models and softwares which are available which can predict this. There's also a very important ratio called SFLT1 and placental growth factor. And this ratio, this interesting article in the New England Journal of Medicine, it can predict the time to delivery. And if this ratio is less than 38, means this woman is low risk. But if the low ratio is more than 85, then that means she is high risk. And FIGO also recommends using all these parameters to predict preeclampsia. And high-risk patient should be started on dose of aspirin 150 milligram to be taken every night from as early as 12 weeks of pregnancy till 36 weeks of gestation. So this is by the FIGO, a pragmatic guide for first trimester screening and prevention. And one of the authors in this is our very own Dr. Hema Divakar. There are new screening methods also, like maternal ophthalmic Doppler, or there could be late screening like Congo Red bound test or glycosylated fibronectin. These are the new methods. But there is a huge unmet need for diagnosis. Not everyone can afford doing these biomarkers. So what is the method, other method? There comes HDP Gestosis score, an Indian innovative screening tool for prediction of preeclampsia. And the Gestosis does a huge amount of work in our country, led by Dr. Sanjay Gupte, Dr. Girija Wagh, Dr. Alpesh Gandhi. And talking about the Gestosis score, which was originally developed by Dr. Gorakh Mandrapkur and modified by the team of Gestosis India, Gupte sir, Dr. Sujitra Pandey, Dr. Girija, Dr. Alpesh Gandhi. And the objective is, it's very simplified method of assessing the maternal risk factors and for screening that yes, this patient is at risk for preeclampsia. So there's a specific process of risk scoring, mild, moderate, and severe, and each high risk factor is given a score. And if the score and the addition of the score is done at the end of taking a very careful history, and at the end, if the score is more than 3, that means this particular lady is at risk for HDP. Anemia, GDM, hypothyroidism, mean arterial pressure, and maternal weight gain are the 5 dynamic factors which can be assessed in each trimester. Now, going through the risk factors, there's an app which is available on Android phone, and it is recommended that all of us should have this list with us in the OPD, and whoever is taking the history can just tick mark, and detailed history is automatically taken. So taking a printout of this and taking a lot of Xeroxes is going to help us take a detailed history and identify preeclampsia at the earliest. So looking at the risk factors, age more than 35, age less than 19, anemia, obesity, even a small duration of cohabitation, women who themselves were born as small for gestation age, family history of cardiac disease, PCOD, even PCOD patient gets a score of 1. Conceived with IVF, yes. It said there's defective placentation when conceived with IVF. chronic vascular disease, excessive weight gain, and so on. And a score of 2 is allotted to maternal hypothyroid, preeclampsia, diabetes, obesity, multifetal. Minute there's a twin gestation, then the score becomes 2. Hypertensive diseases during pregnancy, even mental disorders gets a score of 3. Thrombophilia is 3. Maternal CKD is 3. Autoimmune disease get a score of 3, and pregnancy via surrogacy gets a score of 3. And if you compare this HDP gestosis with the ACOG guidelines, ACOG also says that uterine artery Doppler studies have limitations because of the machines, the methodology, the software that is used. And these are all mathematical modeling which have been derived. So it is better to use clinical risk factor screening method to start prophylaxis, because minute we take a detailed history, we can identify the high-risk patient for preeclampsia. And the aim is to start aspirin as early as possible, low-dose aspirin as early as possible. And this can be done by taking a detailed history alone. So the NICE guideline also recommend this, that clinical risk factor-based screening is strongly recommended. The HDP gestosis score actually has high sensitivity and high specificity, and the diagnostic accuracy of HDP gestosis score has been studied, has been proven by many studies. The Jammu study showed it had 80% sensitivity, 97% specificity. The Vishakhapatnam study also concluded the same, and right now many studies are ongoing. So minute you identify the high-risk patient for preeclampsia, patient should be put on aspirin from 12 weeks of pregnancy till 36 weeks of pregnancy. Early aspirin helps because aspirin balances the level of thromboxane A and prostacyclin, and this helps in adequate uteroplacental flow. Aspirin low dose has lot of maternal safety. So you can, a lot of literature is there to support the use of low-dose aspirin. So to summarize, HDP risk factor based screening for HDP is cost effective. ACOG and NICE guidelines also recommended. HDP's gestosis score is practical, doable. It's a promising tool with good positive predictive value, high sensitivity and specificity. Also, whenever possible, the newer tools of combination of low maternal serum concentration of placental growth factor, uterine artery pulsatility index, maternal parameters, this is all based on mathematical modeling, math modeling, software and all. And in high resource setting, it is recommended, and if possible, it should be done. So choosing the right investigation for the right pregnant patient is important. And the right to survive pregnancy and childbirth is a basic human right. With this, I would like to thank you for listening to me, and I seek all your blessings as I go in for election, seeking your blessings for the post of Vice President Foxy West Zone. The election year is 2025. Thank you, everyone. Yeah, I have stopped screen sharing.
Yeah, thank you, ma'am, for the wonderful and elaborative talk. I request Khushbu madam to give her inputs and closing comments.
Thank you, ma'am. It is a very informative and interesting and as well explained session taken by the madam. This topic is quite complicated to understand, but she made it very easy to understand. And she mainly focused on addressing on the preventive modality as well as the early diagnosis, which could be missed because of our routine busy schedule in the day-to-day practices. We have to focus on these things to make to avoid the complication in the future of this patient. And again, she had emphasized on the role of aspirin for prevention of the preeclampsia in the high-risk cases. And she put her effort to make this topic easy to understand. Thank you, madam. And blessing from our side for future tenure.
Thank
Really
you.
very informative session, Vaishali. And nowadays in Kota also, all the gynecologists, they are doing uterine artery PI also. They are trying to do along with the dual marker. So as far as prevention is concerned now, I think every gynecologist should learn sonography and every gynecologist should learn how to do the Doppler. Thank you very much.
Rightly said, sir. Checking for uterine artery, uterine artery is quite stable and it's easy to measure the uterine artery
Level, yes.
pulsatile. And there's a learning curve of only 8 to 10 days. So
Yes.
any obstetrician can learn it really. And thank you, sir, for your valuable inputs
And all the best, we are with
All
you.
the best, ma'am.
Thank you. Thank you, Dr. Khushbu, for your very elaborative about whatever I spoke and the way you described. Thank you very much. Thank you.
It's quite a nice, and ma'am, it is very informative because it is very difficult to understand the preeclampsia in such a easy way. You explain
Right.
each and everything in very small and bit and easy way. Thank you, ma'am. Thank you so much.
Thank you.
Thank you, sir.
Thank you, sir. Thank you.
So with this, we move on to the next session, and for chairing the next session, I would like to call upon Dr. Ritika Mathur, madam. Can we have a CV, please? Yeah, so Ritika madam, she is at present the president of Kota Society. She graduated from SMS College Jaipur and postgraduated from RNT Medical College Udaipur. She's a specialist in the art of vaginal delivery, and her field of interest includes high-risk obstetrics. She's having almost 25 years of experience in private practice. And most important, she's very humble human being because she sent me the most smallest of the CV, and she said that this is enough. So I mean, it speaks volumes of her. Welcome, ma'am. Welcome. We are very happy to have you. And along with Ritika madam, I will be chairing the session. Myself, Dr. Sandhya Meshram. I'm a fertility consultant at Cloud9 Hospital, Pune. So welcome, madam. Welcome, Ritika madam. And to give the talk, I call upon Dr. Suchitra Narayan. She is the secretary of Ajmer Society, worked as an associate professor in Lady Hardinge Medical College, New Delhi, member of scientific committee on in 2017 at LHMC for National NARCHI Conference. She has 13 years of experience dealing with critical obstetrics and gynecology, published many papers and research articles in renowned national and international journals, written a chapter on women empowerment in Handbook of Social Obstetrics and Gynecology, and currently, as I said, Secretary of Ajmer Society, Foxy Branch. Area of interest, high-risk pregnancy and gynecology. Welcome, madam. Ma'am, you can start your talk.
Good evening, all. And first of all, I thankful to Pune Ajmer Obs and Gynae Society for inviting this nice session and even the needed topic, that is iron deficiency anemia. And I'm thankful to Dr. Aarti ma'am. She's a president Pune Obs Gynae Society. Dr. Meenakshi ma'am, the General Secretary, Pune Obs Gynae Society, and to Dr. Sandhya, thank you so much for your kind cooperation and inviting for such a nice session. But I'm facing a little difficulty. I'm not able to share my screen, so if it will be helpful to if someone can share. Hello. Yeah.
Yeah,
thank you. So shall I go?
Yes, ma'am. Yes, ma'am. Please.
Yes. Okay. Thank you so much. So this is a very important one of very common, even we are in routine, we are discussing about and treating the iron deficiency anemia, comprehensive management of iron deficiency anemia. A gynecologist means our perspective, guidelines and insight and what are the best modalities which are available in a current scenario. So next, please. Yes. In iron deficiency anemia, hemoglobin synthesis is limited due to the lack of iron. Consequently, it will lead to a person anemic. There are 3 phases of iron deficiency anemia. The last one is the phase of that is clinical anemia. According to WHO, anemia in pregnant women is defined as if hemoglobin level is less than 11 gram per deciliter. This is the most common cause of anemia during pregnancy in developing countries. There are, in a worldwide, you can see 14% incidence of anemia in developed countries and 56% in developing countries. Please, who is dealing with this slide? Change next.
I'm just the next so that Mr. Aman
Yes.
can change the slide. Aman, when ma'am
Okay.
says next, you can change the slide.
Okay, fine. So IDA is estimated to cause 22% of maternal death worldwide. Overall, 1/3 of the pregnant women are anemic in the whole of the world. So please next. Concern about the IDA during pregnancy in Indian context, if we see, then there are the 3,26,000 estimated maternal death as well as 12,497,000 associated disabilities with the anemia only. Next, please. And next. There are the few factors that are responsible for the final representation of anemia, that are distal causes, intermediate, as well as the proximal factors, and few are the biological drivers. In the distal factors, there are few ecological factors. Intermediate, out of the intermediate, there are socioeconomic factors and healthy household environment that is responsible for the anemia. Out of proximal causes, that are the three types of proximal causes: maternal characteristic, dietary intake, the less intake, and if there's a availability of food and the nutrients, and health services utilization. These are the proximal factors on which we medical fraternity works to correct and treat. Few are the genetic hemoglobin disorders, blood loss, nutrient deficiencies, and exposure and responses to infectious disease. Finally, these all factors are responsible to decrease, either they leads to decreased erythrocyte production or the increased erythrocyte loss, and that will reflect as an anemia in reproductive age group. Please change the next. So this is a pathophysiology of iron deficiency anemia in pregnancy. There are the three factors during the pregnancy because of dilutional effect of blood, in which the RBC expansion occurs approximately 25% and blood volume expand for 50%, that is almost double. During the placenta development, body needs iron supplementation extra, and the fetal requirements are also there. Next, please. Iron requirements is 9 times higher during pregnancy. In a non-pregnant patient, only 0.8 milligram per day iron requirement as compared to pregnancy. During pregnancy, 7.5 milligram per day. That is 9 times higher. And this is the table showing that the gross iron demands, like 230 milligrams obligatory iron losses. For the newborn baby requires 270 milligrams, and placenta and umbilical cord 90 milligrams, and blood losses that are expected during the delivery is 200 milligram elemental iron. So total gross is 1240 milligram, and so that's the total net iron demand is 630 milligram during the whole pregnancy. Next, please. Anemia screening. This is the guidelines, both the ACOG, renowned ACOG, and the RCOG guidelines. There are different guidelines for the anemia. If a primary or any gravid patient comes to us with an antenatal checkup, then at the first trimester, first CBC, then at 24 weeks, and then 28 weeks and 36 weeks of gestation as per ACOG. But RCOG says the extra CBC requirement, that is on the 24-week only if the patient is carrying the multifetal pregnancy. So in cases of twin or triplet, we have to go at 24, otherwise only 3 times at first visit, 28 weeks, and then 36 weeks. Next, please. Diagnosis, how to diagnose the iron deficiency anemia in a pregnant woman? Definitely with the hemoglobin concentration. This is the absolutely dependency on hemoglobin concentrations, lack adequate. This is a little bit less sensitive and specific for the IDA diagnosis, although it's widely available, easy to measure with the low cost, but cannot be utilized to diagnose the other conditions beyond the iron deficiency anemia. Next, please. So there are few other markers that are the transferrin saturation test, hepcidin levels, and serum ferritin level. These are very specific for the iron deficiency anemia. If TSAT, that is transparent saturation level, that is serum iron if divided by TIBC, total iron binding capacity. If ratio is less than 20%, that shows the pure iron deficiency anemia. If it is 30 to 40%, then definitely there are normal to adequate iron sources are there. And if it is beyond 60%, then the free iron levels are more in the body and that can damage to liver. So these are the iron biomarkers that promise to refining the diagnosis of IDA in the pregnant women. Next, please. These are few newer RBC parameters specifically for iron deficiency anemia. Out of these, there are three things we can see. The hypochromic microcytic, if the concentration is from 3 to 4, less than 3.4%, and hypochromic reticulocyte less than 3.7%, they indicate iron deficiency anemia. If there is a reticulocyte hemoglobin content that is less than 25 picogram, this shows this is an early indicator of iron deficiency anemia, and these patients mostly respond to iron therapy. If the microcytic reticulocyte ratio is less than 3.7, that is when we have to proceed for thalassemia screening. So these are the newer parameters which are very beneficial for the to refine the other diagnosis. Please, next. In a postpartum anemia, what are the effects and causes? Postpartum anemia may basically what could be the most probable causes if the patient has remained anemic since the antenatal time, and if there are the acute of PPH was there during the intrapartum period, that will lead to postpartum pregnancy anemia. Please, next. Diagnosing the postpartum anemia is a complex hematological changes in the aftermath of childbirth. According to WHO, PPA, how can we make a diagnosis of PPA? That is, if hemoglobin level less than 11 gram per deciliter within a 1 week after delivery. These are the three major causes for the PPA. Next, please. These are the complications of postpartum anemia: tiredness, breathlessness, palpitation, infections, particularly in the UTI as a UTI. And PPA finally leads to reduce the cognitive performance of a female and induce the emotional instability, distress, and increase the risk of postpartum depression. It may cause women to experience difficulty in carrying their newborn and lack in the breastfeeding. And so now this is all about the anemia. Comes to the recent modalities which are available and how to treat the anemia. How to treat anemia. Next, please. And next. Approach to iron deficiency anemia during pregnancy. What are the different things which we can start from the lifestyle changes, then dietary modification, supplementation, pharmacotherapy, and last resources that we have blood transfusion. Next, please. Lifestyle associated changes, what we can do, that is that reflect if the lifestyle changes is not being done, then the low birth weight and the preterm deliveries, and smoking is a very important factor that we have to counsel our patient to change the lifestyle. Again, the coffee is less harmful than the tea, as because coffee reduces 60% iron absorption in comparison to tea that decreases up to 80% of the iron absorption. Next, please. So here, by nutritional supply, we can only supplement to 35% in the first trimester, up to 41.5% till the third trimester. So only nutrition is not the remedy, not the very best approach for the iron deficiency anemia correction during pregnancy. Next, please. Dietary intervention which we can suggest to our patient to improve the iron status during pregnancy are these all, like spinach, beetroot are the plant-based food. Again, there's a meat factor, that is chicken meat, that have a amino acid with the sulfur that have a positive impact on iron absorption, as well as the cereals also. They also improve the hemoglobin values after first trimester. Next, please. Dietary intervention, what we can improve for the iron status, same as the previous slide we are discussing. The vitamin fruits which are rich in vitamin C, improve the iron bioavailability. Again, ascorbic acid that prevent the formation of low soluble ferric compounds. So it enhances the absorption of iron, and pregnant women must avoid having tea or coffee, as we have discussed in our earlier slides. It reduces the 80% and 60% of iron absorption. Next, please. Supplementation. Next. Supplementation. So after supplementation of iron is the key to correction of anemia. That is, in the absence of supplementation, what happened in the absence of supplementation? Loss of bone marrow iron store that triggered in women, and it leads to decrease in serum ferritin level, decrease in hemoglobin concentration of approximately 0.5 gram per deciliter. That is recorded by till the end of the pregnancy, and these depletion of iron store subsequently leads to a fulminant iron deficiency anemia and its consequences. Next. Management of iron deficiency anemia. How will we decide when we have to take a step? If the hemoglobin level less than 11 gram per deciliter according to WHO, then go for a serum ferritin levels. Serum ferritin level, if it is more than 30 and if MCV is less than 80, then recommended hemoglobin electrophoresis for the alpha thalassemia testing. And if MCV is more than, means 90 to 100, then we have to go for a B12 and folic acid deficiencies screening. But if the serum ferritin level is 30 nanogram per ml, then go for step by step, week by week. If the period of gestation is less than 14 weeks, and then oral iron supplementation, and then again go for a recheck after 4 to 6 weeks, CBC. If the patient is here, we have a patient from 14 to 28 weeks and hemoglobin is 9 to 11, then again suggest the oral iron therapy and check CBC in 4 to 6 weeks. Recommend IV iron if there is a persistent anemia even after the 6 weeks of oral iron therapy. If hemoglobin level is less than 9 gram per deciliter or high risk factors are there, then we have to go for IV iron therapy. If patient comes to us after 28 weeks, then recommend IV iron to replenish her iron deficit, usually at the dose of 1000 milligram for the moderate to severe anemia. These are the few factors, high risk factor, where we have to be precautious. Next, please. Therapeutic for the IDA in pregnancy. Therapeutics are like, yes, next, please. Next. ACOG suggests that oral iron is the considered first line treatment for IDA treatment. And next, CDC also recommend oral iron therapy as the first line, and we have to go for oral iron first. So next, the absorption of oral iron increases with increasing dose of oral iron up to 160 milligram per day. This is the maximum limit. Higher the serum ferritin levels are observed, then oral iron supplementation taken between meals or at the bedtime. These are the few studies which showing these results. Means nowadays we can advise our patient for the better compliance and better absorption, alternate day iron therapy. The dose of oral iron is directly proportional to improvement in hemoglobin levels. However, the mild GI disturbances could be there. Alternate day dosing is best. Next. So these are few oral iron formulations that are available. That is ferrous iron salts. Definitely these are inexpensive and mild GI side effects are there. With the polysaccharide iron complex potentially having the low risk of GI intolerance, better taste profile, but these are again less effective than the ferrous iron sulfate therapies. Heme iron is having higher absorption with a little less side effects, but although it's expensive, not a very good choice for the vegetarian and vegan individuals. Carbonyl iron, again, it's inexpensive, but there's no any clinical safety and side effect benefits as compared shows. Iron protein succinylate, that is, some data shows that it is having a better tolerability and better bioavailability. But again, this is unsuitable for the hypersensitive person. And iron amino acid chelate, again, it is more expensive. Next, please. So here there's a drawback of oral iron therapy. Definitely, there are GI adverse side effects are there. Lack of adherence to therapy, less compliance, insufficient length of therapy. Even if the patient is moderate to severe anemic, then the correction of anemia chances are little less, and limited duodenal absorption due to concomitant GI pathology. Next, please. Blood transfusion as anemia correction therapy is it right, or it is an effective method to treat anemia, definitely. But after oral iron therapy, directly we can't jump on a blood transfusions. It is effective in the patients with severe IDA. Rapid anemia correction is clinically necessary when these are the indication of blood transfusion. Next. However, blood transfusion is associated with some risk. Obviously, there are social issues, patient beliefs, and apprehension, scarcity of the blood and blood products. Incorrect transfusion can lead to a hypersensitive and anaphylactic reactions, adverse impact on patient's immune system. Post-transfusion reactions are there. Next, please. So, what is the role of IV iron therapy in pregnancy? IV iron in pregnant women is if there is no any improvement after oral treatment, developing serious side effects with oral iron therapy, and severe anemia patient if not responding to oral therapy, then the IV iron is the better choice. But we have to restrict it up to second and early third trimester of pregnancy for the IV iron. Next, IV iron sucrose. As since years and years, we obstetricians are using iron sucrose therapy. The safety of IV iron sucrose being comparable to standard oral iron therapy in pregnant women. The safety and efficacy is more well studied, and very minor side effects are there with iron sucrose. Next, please. IV low molecular weight dextran. This is a time-saving and cost-effective option for iron administration. 1000 milligram IV over 1 hour, but it is little time-consuming. 60 minutes, at least minimum 60 minutes it requires. First American prospective study of IV iron in oral iron intolerant iron deficient gravidas were studied with the IV low molecular weight dextran. Although we have very recent other formulations in IV iron. Next. Sorry. So newer iron formulations are there, that is ferric carboxymaltose, iron isomaltosides, and firmoxetol. FCM is a parenteral iron dextran free product that is approved for rapid high-dose iron replenishment. It consists of a ferric hydroxide core and carbohydrate shell that allows the controlled iron delivery within a very minimum time. Next, please. So here, these are the few side effects with IV iron. These are the few IV iron formulations that are low molecular weight iron dextran, ferric gluconate, iron sucrose, firmoxetol, iron isomaltoside, and ferric carboxymaltoside. So side effects are least with the ferrous isomaltoside and the FCM preparations rather than the ferric gluconate. Sorry. So if we compare all these, the maximum dose that is required in a single shot, that is low molecular weight iron dextran and iron isomaltoside and ferric carboxymaltoside, that is 750 to 1000 milligram in a single dose. If we are giving an iron sucrose, then 200 to 300 per dose, in total 1000 milligram, but it requires the multiple doses that are 3 to 5 doses. Side effect are almost same in all these, but FCM is having least side effect. Hypersensitivity reactions are common with all IV formulations and are often mild and transient. Severe reaction generally responds to carbohydrate shell. Most of the individual will be able to tolerate a different formulation. Next, please. these are the few guidelines showing in our different country wise what they are preferring, at which level of hemoglobin they are recommending the IV iron therapy. Next, please. So in a iron deficiency anemia, the role of ferric carboxymaltose. This is the recent molecule. Next, please. This is a dextran-free parenteral iron, FCM. It offers rapid and high dose replenishment of depleted iron stored. FCM is stabilized by the carbohydrate shell. Next. FCM permits the administration of the large doses in a single one sitting. FCM has low immunogenic potential with a high, less side effects are there, and design of FCM permits the delivery of iron, preventing the release of large amount of iron into a serum in a controlled manner. Next. Next. So here this is the pharmacokinetic of FCM that shows 2.6 to 4.4 ml per minute mean plasma clearance, and the T-half is 7 to 12 hours. Mean volume of distribution is 3 liters. So after a single 100 milligram of IV iron dose of FCM solution injected over 1 minute, serum iron concentration reached at the peak within 15 minutes. Optimal timing of FCM administration is FCM in a single dose of 1000 milligrams. Next, please. Next slide. Yes. FCM in a single dose of 1000 milligram administered during 12 to 24 weeks. As we have discussed, second trimester is the best for IV iron supplementation to substantial improvement in the iron status. And FCM in the last, if we are giving in the third trimester, then it should be at least 2 weeks prior to the expected date of delivery. Next. These are the few clinical studies confirming the reality. Next. Next. Treatment with the FCM demonstrated improved indices in manner of hemoglobin, serum ferritin concentration, and transferrin saturation levels. Although when it was compared in a postpartum anemia, FCM improved the quality of life in comparable to oral ferrous sulfate in patients with inflammatory bowel disease, AUB, and congestive heart failure. Next. When we compare it against the other IV formulation, the rate of side effects, adverse effects are similar in the FCM, but FCM is reported to exert lower rate of dysgeusia and hypotension in comparison to other IV iron formulation. Next, please. So here the FCM related associated adverse event, as we all know, there are very least side effects are there in terms of with other that are associated with other iron preparations, that are decreased phosphate level, hypophosphatemia, dizziness, flushing, all these. Next. Next. So in this PROMISE study, next please, we summarize that this is the study done on 1800 of pregnant women with IDA, and it shows it was assessed that efficacy and safety of IV FCM in adolescent as well as the IDA patients, and that shows, next please, next, that shows a pregnant women with IDA improve the hemoglobin level, serum ferritin levels, and also the transferrin saturations level. These are the few exclusions were there. If the patient having hemoglobin less than 4 gram, first trimester, hypersensitivity, and these. Next. 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 FCM in the management of IDA in pregnancy, that shows these three things. Hemoglobin level was increased by 3.6 gram per deciliter, serum ferritin by 16.96 microgram per liter in women with moderate anemia, 7 to 9.9 gram per deciliter. There was an improvement in hemoglobin by 2.74 gram per deciliter. Women with mild IDA, a rise of 1.99 gram per deciliter hemoglobin was recorded. These was the results and interpretation of that real observational study. Next, please. So FCM management in IDA pregnancy, this is again another subgroup analysis which was done, and that shows the single FCM injection of 1000 milligram is a crucial treatment for correcting anemia and restoring iron store in pregnant women experiencing moderate to severe anemia in late second trimester and early third trimester. Next. The mean rise of hemoglobin at 12 weeks was significantly higher in the FCM group. FCM was associated with a greater improvement in a fatigue score, and number of visits were less required in FCM group. No any serious side effects and the events were noted in other groups. So FCM has the advantage of large dose administration only in a single sitting. So this is the crux of our FCM studies. In a prospective study and a prospective comparative study, two were done in 2016 and 13 with the comparative results. They shown that very effective in improving hemoglobin concentration in an early replenishment of iron store. Next, please. Next slide. Next. So here, this is the summary of iron deficiency anemia induced complication in mother. As we all know, in mother during an antenatal period, it leads to preterm labor, placental abruption, severe PPH, preeclampsia. Due to PPH or anemia, the patient will end up in hysterectomy, shock, increased ICU admission, and maternal death could be there. Next, on a newborn, preterm birth, low birth weight, small for gestational age, fetal distress, cognitive disorder, intellectual disability, and iron deficiency anemia in newborn could be occur. Next. So FCM is a better choice during pregnancy as we have discussed in detail. Yes, it is. Next. The FOXI recommendation regarding FCM is the FCM is a dextran-free IV oral IV iron preparation that allows rapid administration of high dose of iron. And in postpartum anemia correction, it is also having a best role. So compared with the other parenteral iron preparation, FCM has several advantages like fewer side effects, high dose administration in a single sitting with the better bioavailability, better tolerability, and fastly correcting the anemia. Next. Next slide. Next. So these are the few slides having with the Anemia Mukt Bharat. As we all know, these are the criteria of hemoglobin level during pregnancy. Either no anemia, mild, moderate, and severe. So National Technical Expert Committee on FCM says, yes, this is the best IV iron therapy, can get easily administered during pregnancy as well as in a postpartum anemia. Next, please. Indications, as we have discussed, moderate anemia during pregnancy after first trimester, after 14 weeks. If oral iron is not tolerable, non-compliance to oral iron, no any improvement of hemoglobin, or it is less than 1 gram per deciliter, even after 4 to 6 weeks of oral iron therapy. Moderate anemia after 32 weeks of gestation due to iron deficiency. In patients with severe iron deficiency anemia due to iron deficiency at 13 to 34 weeks of pregnancy. Next. So guidance note is, this is the how to calculate the iron deficit. That is total iron deficient is equal to 2.4 multiplied body weight and in kilograms multiplied by hemoglobin deficit, that is target hemoglobin in gram per deciliter minus actual hemoglobin in gram per deciliter plus 500. Next. This is how to administer the FCM. And in nutshell, we summarize in a single slide. IDA is the most common cause of anemia during pregnancy. Next, please. Treatment aspect of IDA include lifestyle changes, supplementation, dietary modification, blood transfusion, and pharmacotherapy that are oral and IV iron. FCM has demonstrated the therapeutic efficacy for conditions associated with absolute or functional iron deficiency, either with or without anemia. FCM is reported to be effective in treating IDA as well as postpartum anemia. Studies confirm that the safety, efficacy, and tolerability profile of FCM, Anemia Mukt Bharat guideline also suggests the use of FCM in pregnancy as well as in a PPA in a patients of IDA. And this is also a core component of Anemia Mukt Bharat. Compared to other parenteral iron preparation, FCM has the different advantages. So thank you so much for patience hearing, and if there's any query and question, thank you so much, Dr. San and Meenakshi ma'am. It was quite lengthy, but it's very important topic.
Thank you, ma'am, for such an elaborate talk on iron deficiency. You've almost covered everything, starting from pathology, pathophysiology, till the treatment modalities. I request Ritika Mathur, madam, to please give her comments on the talk.
Ma'am, it was an excellent talk, although I had to miss some of it because I was called for an emergency. But as far as I heard, it was very good. And ma'am, I would like to add, like, we are from the region of Kota, Rajasthan. And fortunately for us, our speaker of our Lok Sabha is from this place. So in Kota, we have a Surakshit Matratva Abhiyan, in which all the female who are from the lower socioeconomic groups, they are given a packet. If they get themselves registered on the recommendation of the gynec, they get a packet of nutritious food given every 2 to 3 months. So I think that is a very good initiative, and I think Government of India should start it all over. And I think FCM should be provided in the government setups also, ma'am.
Yes, ma'am.
I
It
don't
is
This is
provided by
provided.
the
Very nice.
This is there in government setup.
Yes, ma'am. It is available in government setup.
It is
It is a
available.
very informative and updated topic. You have covered all the things of the iron about oral
Because I had
supplementation,
to leave in
iron.
midway, and I asked my secretary to sit through the whole talk, and she had to. Yeah, it was a very nice and informative talk, and thanks to Pune Obs and Gynae Society for involving Kota Obs and Gynae Society. ma'am.
We
Yes,
are
from Ajmer Obs and
And
Gynae
thank
Society.
you, Khushbu, also, always.
Thank you,
And,
ma'am.
Thank you, Suchitra ma'am. Excellent talk, a very detailed
Yeah.
talk. You took us through everything, all of it at
Thank
one
you,
go.
ma'am.
So really enjoyed your talk. Thank you so much. And such expert comments from all of you, and your valuable presence was, really great feeling for us at Pune Gynec Society. And really enjoyed. I think this is the first webinar we are doing with Ajmer Kota Societies. So
Yeah.
really enjoyed a lot with all of you.
Many more of such webinars, ma'am.
Yeah,
Exactly. This is very. Yes.
संध्या सुचित्रा मॅमचा आवाज आणि ऍक्सेंट एक्झॅक्टली तुझ्यासारखे
Okay.
सेम है ना
Uh,
मला वाटलं तूच बोलतीस
Aarti madam is saying Sandhya is sounding like Suchitra ma'am.
like Suchitra
Yeah.
madam.
Oh, thank you so much. It's a
Same,
great
same.
compliment, ma'am.
Yeah.
But thank you to Sandhya ma'am.
Recording
And
stopped.
great effort she did on a very short notice as we are searching for CV.